All right, we are live. So let me just first start by welcoming everyone who's probably tuning in to watch this when it gets posted. I appreciate you taking the time. I'm here with my man, Seth Oberst, Dr. Seth Oberst, who I'm very excited to have on. Seth, how you doing, buddy?
I'm good, man. I'm good. Thanks for having me on.
Yeah, Team Yellow shirt tonight. We called each other in
Yeah, we're repping.
agreement. All of our shirts take AA batteries we talked about. So,
That's right.
let's get started with just, I know if anyone's not following Seth's blog, you are seriously missing out. He's a smart kid and has a lot of cool, I guess, outlooks on the way we look at human movement. So, Seth, by just start by talking about, I guess, where you're from, your background, what got you into like healthcare and training, and what you're up to now.
Sure. So I grew up in Ohio. I went to University of Toledo for my undergrad in exercise science, and then I got my doctorate in physical therapy at Ohio University. After kind of going through that kind of route, originally I got into to exercise science and then into physical therapy because I want to kind of I wanted to impact the whole system.
Mm-hmm.
And I felt like physical therapy was the best way for me to be able to work with people across the spectrum, and really kind of address all body systems. Certainly I continue to appreciate that more now as I get into this field. But certainly that was the genesis there. After I graduated from PT school a few years ago, I did a residency in South Carolina, sports-specific residency, kind of for more training in sport-specific care and kind of managing athletes kind of along that spectrum. And so after I did that, I got my board certification in sports specialty, and then I've kind of been working, I work with athletes and I enjoy working with athletes, but I really enjoy working with kind of a variety of people and dysfunction. I kind of look at myself as a bit of a detective in that I always like fixing problems, and so when people come to me with problems, I really take it upon myself to try to figure those out. So I see people from kind of a variety of spectrum. I see quite a few people with persistent pain syndromes.
Sure. I think it's probably going to be the first topic we kind of dive into, is both you and I are, I think it's kind of how we got connected very much, is it between Joe, obviously, our friend Dr. Joe Meyer, but also we're both really kind of actively looking and seeking out a lot of the role of the nervous system and the brain and things that I never would have ever considered in my traditional physical therapy outlook about the nervous system and how it impacts people with chronic pain like we're talking about. But also, I think the same movement principles and the same neurological principles have huge carryover to the athlete and like tapping into this like next level performance. You know what I mean?
Absolutely. And I think, the kind of the cliche is everybody has a nervous system, and it really is all neuro. Because if we don't, I think if we appreciate what we're truly impacting on a minute-by-minute basis, I think that makes our interventions, our diagnosis and evaluations, but also our interventions more specific, because we have an idea of the mechanisms that we're affecting. And don't get me wrong, we're affecting numerous systems, but I think until we have an idea about what we're doing to the brain and the nervous system, we don't really have a great idea of the mechanisms of our interventions. And so that's really something that interests me is how can we optimize the things we're doing and the things we're seeing for the idiosyncrasies of that client.
Yeah, I agree. And I think, I'm kind of back and forth too with you. I think, traditional physical therapy, very mechanical biomechanics idea, right? Came out of PT school, learned a lot about PT science, kind of pendulum swung the other way, and I was way heavy into neurophysiological, right? And now I'm kind of finding the midline, like you said, it's all systems together, but it's really incredible because ultimately the brain and the nervous system really dictates whether our interventions and how we interact with our patients, our clients, changes what we hopefully want to change, right? That's the end goal. Does the brain and the nervous system accept what we do, or is it, unfortunately shut off guarded and doesn't really want to take part for whatever reason?
Absolutely. And I think, once that kind of input is integrated as an output, then we can kind of make those more once neuroplastic changes are realized, I think that follows closely and sometimes simultaneously with bioplastic changes. So, hypertrophy and changes in connective tissue length and all these other things. But until we've changed the way that the brain perceives those interventions or those stimuli, then we can't really affect bioplasticity, in my opinion.
I agree. I think a lot of short-term things we do, manual therapy, we see a huge change in range of motion, whatever it is. I think the short term, anything short term is probably neuro, right? We didn't change tissue, that
Right.
takes time. So I think like we had talked about before over text message, that the short term will probably see a lot of neural changes, but those neural changes, if used properly and consistently and accepted by the brain and the nervous system, lead to mechanical, bioplastic changes in tissue. Would you agree?
Oh, 100% agree. Absolutely. And those changes are those changes are inherent to the system. Whether context is what makes them good or bad. So these same changes that we're affecting, hopefully in a positive manner, are also being affected on someone through parafunctional habits. So how they perceive the world, how they move about the world, the positions that they hold themselves in. Those cause changes, first neuroplastically and then bioplastically. And so the same things occur when we're working with them. So absolutely, I agree with you. It's like, could their hamstrings be tight? Maybe, maybe not. Depends on what how they hold their body in the positions. We adapt to the positions that we're in, both neurologically and physiologically. So
yeah, and I think that's an important point you brought up, was that negative or positive, right? You know what I mean? Like,
yeah, it's context specific. It's context specific. Absolutely.
Yeah, and that's kind of cool. Is like, I think there's a lot from the work that I read from you, especially talking about neuroception, like, subconscious threat perception, which I definitely want to get into, is like what we say, what we do as healthcare providers, therapists, coaches, the way we present ourselves, the way we make decisions, the way we're interacting. I think that is a huge, kind of pathway into what our athlete or client receives based on our ability to talk with them and be with them and set up, like you said, an optimal learning environment like you wrote about.
Absolutely. I mean, I think that is the basis for what we need to do. I think we really get nerded out on some of these biomechanical principles and kind of trying to parse out these sometimes pathoanatomy. Although you and I know, we're not big into the pathoanatomy as the onset. But I think until we address these underlying base principles of neuroception, which is the subconscious evaluation of threat to the organism, until we address some of these basics, I think it doesn't really matter what we do. Right. Certainly, it doesn't matter it's not nearly as important as addressing those baseline measures first.
Yeah, and we'll kind of go into that now, because I haven't read the polyvagal theory and subliminal yet. It's on my list of things to do, but I guess I agree with you too. It's like, how can we expect the nervous system, the brain, any movement to change if an athlete is not okay with us setting up whatever we're doing, or a patient comes in and we dump heavy medical terminology on them, their kind of eyes are glazing over. Like, talk about how that whole idea of neuroception plays into a practical application of either high-level sport or just someone in the mom with back pain.
Sure. Well, I think I think that there occurs. So, like I said, neuroception is that subconscious evaluation of threat, and so that's an evolutionarily defined trait where the organism is essentially just determining on a second-by-second basis, even milliseconds, really, of how is the environment impacting that organism? Is it safe or is it dangerous? If that environment is safe, or the task is safe, and I think we can divide those out in environment and task, meaning, do I have the skills or the abilities to perform the task that's presented in front of me? That can be perceived as safe or dangerous. If it's safe, then the vagal system through the parasympathetics are facilitated, and the organism can engage in the environment and engage in what you're doing. They can pay attention, and they can live in their cortex. On the flip side, when you think about something that's dangerous, and that danger is different for every person based on kind of this mature organism model where everything that we perceive is filtered through our preconceived notions, our knowledge, our beliefs, our memories, and certainly all the receptors that are acting. And so if that is then perceived as dangerous, then the fight or flight system kicks in, sympathetic dominance starts to override, and by definition, that person cannot engage with what we're asking them to do. Their brain is noisy, and so a noisy brain is a brain that can't pay attention. And if you can't pay attention, you can't learn. And so I think what I find is that if we can get them engaged, however that is, and that can be, and maybe we'll get into this, but that can be meditation, that can be a smile, that can be eye contact, that can be the way that you present yourself to the client. Once you're able to get them engaged, then you can start to systematically stress them as needed. But you can't, and someone comes in stressed, you can't over stress an already rigid system. You're just going to get more rigidity. And these are these people, you know, I wrote about this, and I think these are the people that are the difficult patient, right? They're the patient that can't pay attention. They don't listen. They don't do their homework, you know, their home exercises, or if it's an athlete, you know, you tell them to do something, they do the exact same thing they just did. That's because this is reflexive behavior. Their prefrontal cortex is inhibited. They're relying more on their limbic system and brainstem to function habitual movements. And so we've got to get them out of that position. So that's kind of really where I start with people. Is how can I get you engaged
Right.
in the environment?
Right. Yeah, that's all, you know, super interesting and stuff that I think is, it's not, people are probably quick to like listen to this and be like, oh, well, that's kind of, you know, out in the clouds, or it's out that, but it's really not, you know, that the
No.
content behind it is very, you know, maybe complex and cool to understand, but it's as simple as, like you said, a smile. Or like, for me, I just had a patient on Friday, right? Being the first person to sit down with them for 30 minutes and talk to them about what probably or maybe is going on in their body, not being like punch in, punch out in a doctor's office, or like, you know,
Absolutely.
like, well, start with me from 2013 when this girl first hurt a hip. I was like, just kind of walk me through everything that's been going on, right? And truth comes to shove, she was like, well, I've had 5 MRIs and this and that, and I had a labral repair and this and that, and like the list was like on. And as she described these things, I could see her like winding up like a cable car, and I was like, wow, it really sounds like you've been through a lot, man. Like you've been a medical pincushion, you know, for unfortunately, maybe you do, you know, did you need some of that? I don't know. I wasn't with you 5 years ago, but we're here now. We're going to do a fresh look. You know, I'm going to give you a top-down evaluation, and we'll start you with things. So it's part of it is like we talked about, is like just being a human, right? You're not a labral tear. You're a person with a normal brain who happens to have a labral tear or labral issues.
That's exactly right.
And then I think you kind of, that's the gateway for me personally, is like just being human, talking to them, what's going on. And then it's like, I do think that you need to have a couple maybe tricks up your bag, or, you know, things manually or intervention wise that people sometimes get hooked and they notice a positive change in the first session. You're like, wow, this actually feels maybe a little bit better. It doesn't happen all the time, but if you can talk to someone and be human and maybe have a couple things that you can do and change it right away, even if it's negligible, you know, you're in there, and they're maybe more apt to open up and be a little more flexible in their nervous system.
That's exactly right. That's exactly right. And when I say engagement, I don't necessarily just mean in conversation. I think I mean exactly what you just said. That engagement is allowing some movement variability, you know, triplanar movement, and we can, that takes us down to that movement path. But until that can be, getting them to engage can be anything that's necessary for that person. Like I said before, that's idiosyncratic. Sometimes that may just be letting them vent out their issues, but it can also be, but we also have to show change, and that's where that comes into the intervention stuff, as you mentioned. But absolutely agree with you. It's got to be specific to that person, and that's where that history comes into play, and really kind of determining what the receptor field is active for that person.
Sure.
You know, what is the trigger? What triggers that neurotag? But you know, and you know, you said something earlier about how kind of it can kind of seem up in the clouds, some of this stuff. But you know, good clinicians and good coaches, they're doing this already. They're already doing this. They don't have a name for it, but they're already you know, excellent coaches, as I wrote about in my Environment for Better Learning and Performance articles, is, you know, the 2 variables that we really look for to get people to inhibit that sympathetic state is consistency and security. They've got to be able to trust you, and not necessarily trust me from I'm not going to hurt you, although that's certainly important, but also trust that we are going down the right path, and then that nervous system can engage. And then consistency, you know, this dyssynchrony of things, where I hear one thing and I see another, that presents a conundrum to the brain, and oftentimes the default is a negative default, because evolutionarily that kind of kept us protected. And so we've got to be very cognizant of what we say and do and how that matters.
I agree, and I think this is kind of where I think common issues we talk about split both ways, right? So in a clinical standpoint, right, being able to have a plan and follow a logical order of your interventions, or like treatment to treatment, you're like, how is this? Let's move this forward. Not being like scatterbrained, right? Not like try that at one, try that over there. Like it has to have a flow, and the person has to understand why they're doing it, and then thinking, you know, coaching wise. If my coach, when I was growing up, didn't have a formal plan, and he was just like tossing stuff out, try some of this, try some of that, I'm like, man, what are we doing? You know what I mean? Like we're all over the place. It doesn't feel organized, and you have to be dedicated to putting in work to find a systematic plan and follow and educate your athletes or clients about what the goal is and what their role is, which is important, right? You know, what do they need to do it's not about coming and just laying a table and get fixed. It's about what do you need to do actively so we can tag this thing together.
Absolutely, 100% agree. You know, some of those things that I think Adrian Lau's talked about is, you know, the things that people that everyone wants to know on their first visit. How long is this going to take? What's going on? What I can expect of you, the clinician or coach, and then what can be expected of me, the client. And so, you know, I think providing that information, that in and of itself, and I'll tell people this, just having some better knowledge of what the issue is, and not necessarily from a pathoanatomy standpoint, but just that overall is crucial.
Yeah. I agree. And oftentimes, we're the first, whether you're an AT, a chiro, a PT, whatever, you're usually the first person who's intervened with them for more than 15, 20 minutes and have maybe had a back and forth fluid discussion. And that's a huge point in the system to be responsible for. Absolutely. So just thinking about kind of, we'll roll down into some pain science stuff or maybe some more movement clinical stuff for people. But, you know, one thing that's always stuck with me between, you know, reading about your stuff, the pain science world, and kind of where I've been at with movement variability research is it's crazy to think about, like when we talk about pain science, like the neurotag ignition and how many places are involved, prefrontal and things like that. If that is busy with chaotic sympathetic stress or, you know, pain neurotag ignition, it's really hard for someone to become more open to learn. And how can we expect someone to get more variable in their movement if everything is constantly flooded the system sympathetically? You know what I mean? Like, so kind of talk about, like, I guess breathing is a good way for us to kind of jump into it, but like, what are some things that you use in the clinic or you do with athletes that either get somebody kind of open to learn more or get somebody out of that sympathetic state, and why it's important? First time, and Google Hangouts absolutely crashed. So we're going to sync these two videos together and just kind of take off, you know, where we were last time. Seth, I like your shirt change. This looks good. We figured we'd go from Big Bird Yellow to patriotic red, white, and blue for the second half of
Yes, for America.
America. All right. So we were talking about, you know, how the nervous system predicts threat on the, you know, both the conscious and subconscious level, how that ties into pain science and how that ties into the clinic and how we can set up an optimal environment to teach people, you know, new skills or, you know, help them recover. And I guess where the best kind of place to transition this to is, so let's talk quickly about just like, you know, your blog on like the resting tone of the nervous system, right? How we need the ability to be on one end of the spectrum, real sympathetic, get jacked up, work out, you know, because both you and I are athletes, right? We love that sympathetic state, but the ability to shift itself all the way back to the other end and be parasympathetic is just as important for some recovery and some variability. So let's kind of just touch on that first, if you don't mind.
Yeah, I know, absolutely. So, you know, when the best athlete is one that's well balanced and can shift not only positionally and from a mechanical standpoint, but I think also from a nervous system standpoint. And so we know that people who are able to have like heart rate recovery quickly, so they're able to recover heart rate or vagal tone quickly after a sympathetic stimulus, recover quicker and they recover more optimally. And so there is this balance, right? I mean, we do need to be, you know, and I kind of wrote about this in my article about this resting tone, is that ideally our resting tone is somewhere kind of in that parasympathetic area. Now, it can't be completely parasympathetic because then you'd be just literally vegetative. So we need to have some sort of alertness and kind of a wits about us. And so there needs to be an arousal level sufficient enough to draw our attention into the skill that we're doing, whether that's learning a new skill or performing one that we've already performed. Now, as sympathetic tone increases due to the needs of the task, we have to be able to meet those needs from a brain function standpoint. What I mean by that is, if someone's super sympathetic and they don't really own a skill or a movement, they're going to revert back to what they know, that conditioned response. And so that's kind of in my opinion, training is really the systematic desensitization of threat. And, you know, we kind of go along those stages of motor learning, right? So we go cognitive, then associative, then autonomous. Yeah. And the goal is, so if it's truly autonomous, then that skill will transfer regardless of the stressor placed upon them. If that makes sense. So like, you know, the higher the stress, if a truly great athlete, doesn't matter what pressure or what the stressor is, they still perform with proper mechanics, proper movement. If you look at kind of like, for instance, CrossFit Games, the difference between Rich Froning and some of the competitors is not horsepower or I think an engine. It's really, he has so finely tuned his movement that even even at high stressors, his movements look exactly the same as they do when he's well rested and just starting. And so I think that spectrum is something that we need to have good balance on. Too many times, and I think you would agree with this, we see athletes that are way too sympathetic. Right. And so they can't learn in that state. They're already doing what they know, right? They're just operating on autopilot. And so whatever that autopilot is, may be good, most likely not good based on what you and I see clinically.
Yeah, absolutely. And I think, people underestimate the negative drawbacks to being chronically sympathetic, right? Constantly, even if for me personally, it's like putting enough attention into your training design, what you do to get somebody in a good state of readiness, what your programming is going to be, like all these things that are, a dosage of training stimulus, right, to get them sympathetic and tax their system. But we lack the ability to look on the other side of the spectrum and say, how are we going to slowly ramp you back down to that parasympathetic shift, right? How can somebody, I don't want someone to leave my workout, like with my gymnast, or if I am training them hard in a whatever hard would be defined as in a clinical setting because they're recovering from an injury. And then you're like, all right. And they go sit in their car and they drive home and they just sit there and they're like, boom, they crash, like a sympathetic crash, right? They go right down.
Yeah.
So we have to slowly ramp them back down to get them into that, recovery phase. What are you going to recover like for the next session? What's your nutrition like? What's your sleep like? What are your other stresses outside but even so simple as like, let's lay down, do some breathing drills before you leave. Let's do whatever recovery work you want. If you call that a light dynamic cool down, whatever it is, you got to exist in the both bandwidths, I guess is the right way to say.
Oh, absolutely. And that's the whole point of this kind of spectrum that we discuss is you should be able to swing, like a pendulum essentially from side to side based on the needs of the environment or the task. And too often we see people stuck. Typically it seems like they're stuck more sympathetic, but I think we're really good at overtraining our athletes and under recovering them. And I think it's like, we've got this kind of mantra that, it's like more. And I think more when it's needed, but this just extra stuff is really kind of, I think, superfluous.
Yeah, absolutely. And it's very taxing on the system to recover from a heavy training load. The allostatic load to get somebody back down to homeostatic is enormous. And we don't see what the person goes through when they're not with us, right? But their system is being taxed to get them back down to a normal, non-threatened, flexible system.
Absolutely. And not even, and to that point, you spoke about how, we don't know what they're doing outside, or ideally we find out what they're doing outside, but we don't always, there's all these stressors that are adding up outside of the training room or the clinic. And one of those that I found interestingly is cognitive load. So, where is somebody at from, are they learning, if we're teaching them how to learn, if we're teaching them new movements and asking them to learn new things, where are they at in the season? As far as sports, but also where they at in their academic season. Yeah. There was actually an article that just came out pretty recently that showed that athletes, I think it was college football, were more likely to get injured during high academic stressors. So finals weeks, midterms. And so it's all cumulative stressor. I think we gotta get away from this dividing psychologic and somatic because it's all, I think it's mostly just divided up by nomenclature, honestly, more so than anything that's actually tangible. It's all affects biology.
Mm-hmm. So. Yeah, and this is the same thing, right? The student athlete with finals is the mom of 3 whose kid is sick, is the father who's going to work who's got a big presentation.
Exactly, 100% agree. Absolutely.
Right. And so whether we're trying to come forward there.
Yeah, I kind of cut in and out, but I'm still with you.
Okay, yeah. So it's this applies to everybody. A lot of people think sports performance and recovery, but Absolutely. It's the same thing as someone who just had. So say somebody blows their ACL out, right, and their function, huge threat in the system, and they're just coming out of surgery. Like what we do with them in the clinic and how they respond to that stress outside of their clinical environment is similar as a very high level athlete coming back from a back injury, whatever it is. It's all the same,
It is, and I think we may have discussed this in our last part 1 of this epic 2-part series, but and now I lost my train of thought. I was trying to drop sweet jokes, and I lost what I was going to say.
Caught and tracked.
Well, I think that look, we've just got to take into account all the stressors, and because they add up, and And I think, one of the things I'm doing too is I'm having people fill out a perceived stress scale actually before they come in, which basically tells me an idea of where they at on this stress scale and how are they handling it. Because, it doesn't really matter if the stressor is real or perceived. The body system reacts pretty predictably, regardless of it. Maybe my heart rate goes up 20 beats per minute when I'm anxious, and yours only goes up 10, or vice versa. But it's pretty predictable, generalized systemic response to stress. And so we've got to figure out what their idiosyncrasies are in regards to how it affects movement and performance.
Right, and this kind of idea that I think is emerging more within pain science and also the stress response literature is about how the thought of pain can influence pain output in a neurotag ignition, or the thought of stress can signal a stress response, or all these and even so in some of Adrian Lau's work talking about how not having the motor imagery and not having some of those somatosensory maps tuned up after an injury, if you're casted or like you're in a brace, because whatever, like you may lose that ability to work with that body part. And mental cognitive exercises are just as important sometimes in that acute phase of an injury to really set the stage for what will become complex motor neuron, interactions.
Absolutely. And one of the, it's funny, in the lab that I worked at in PT school, they actually just came out with an article last, I think in January, on people who are immobilized for 4 weeks, and they had them do essentially motor imagery of contract to relax. They had one group that contracted, and essentially mentally contracted rather those muscles versus the people who were functioning about their day, and the actual strength gains were about the same. So it's not, we can't just limit this to the somatics. I think it's all related.
Yeah, absolutely. And there's so many cool things about how the theoretical idea of what happens up top applies to a very real movement output, right? We talked a lot about how the chronically stressed system can become movement adaptation to be hyperinflated and extended, right? We talked about last time how a very real neuroplastic change can become kind of quote unquote aimed as a bioplastic change. So if these people are living in this stress state with these cognitive things we're thinking about, their system adapts in a movement way that predicts their postural movement predictions, which then may become their mechanical issues that we see in the clinic, right? The person who is poor breathing, overextended, whatever it should be, who presses like garbage, might link back to this trace of mental cognitive things about chronic stress outside the gym. And it's integrally networked, Yeah. It's very cool.
Yeah. And I think the interesting thing is, and I certainly don't have the answers, and I don't know who does. If they do, I'd love to talk to them, but is what comes first, right? Is it the mental cognitive stuff? Is it the motor output? My guess is that, like we talked about, because we know that an input or an output rather immediately becomes an input. I don't know that we've just got to break that cycle. Where we break it, I don't know. I mean, I think, certainly a counselor or psychiatrist would certainly break it more at the cognitive aspect. Certainly we can contribute to there, but I think we have a lot of power to break it on the movement or the output side.
Yeah, absolutely.
And change those sensory inputs. So,
yeah. And it's very cool to think about, especially what I've been into is the thought of variability you were talking about heart rate variability, right? But also the concept of movement variability. And I think, one of the coolest, like we were texting the other time and you're like, maybe there's some not so great ways to move, right? You rotate valgus when you land single leg, probably not the best, but there might not be a set good way to move necessarily.
Yeah, I think you're right. I think the research has shown us a few, and I even think this is a little bit somewhat more sparse than we would like, but certainly there's some ways that we know are not great to move, right? I mean, we know a valgus moment, like you said, is going to hurt, more likely to injure your knee. But there are sports and movements that require valgus movements. I mean, and so it's like, well, what is the difference between the person who can get into valgus in and out easily and doesn't get hurt versus the person who falls into valgus and blows out their ACL once, twice, 3 times? And I think that comes back to this kind of, certainly it's variability and it's control of those variabilities, right? It's I've been here before and I'm safe. Therefore, I can express an output that gets me out of that if need to, or safe while I'm in it. These are the people that are injured right at the beginning of training camp because they haven't been training, they're not variable, or they have been training really hard, but only in 1 or 2 planes and not triplanar movement where they can access all these different positions.
Yeah, absolutely. And I think there's a piece of this that factors into the acute situation you talked about, right? Do you have the strategy? Is this safe for you to do? Can you get out of it? And also, very much so, what I think a lot of people deal with in a very high level competitive or even like a demanding job that's repetitive is like the factors of variability on repetitive movements and repetitive strain that, may load the same tissue over and over. And for me, in gymnastics, there's a very high percentage of overuse injuries, I think, because the patterns that they use are very, very rigid. It's the same exact landing or the same exact extension or whatever it is. And if we don't give them more options to shift the stress around tissues, then maybe we get in a situation where we do get, mechanical noise deception, which is perceived as a threat. CNS says, yep, this is pretty dangerous. And now we get pain output, right? Or we do have a true tissue level inflammatory response, and a cytokine-based action then gets us to a sensitization issue. You know what I mean? There's a very real thought about variability for acute and also for an overuse situation of why this may be mechanically linked to pain science.
Oh, absolutely. I completely agree with you. And I think that's why, and I think you and I had talked about this before at some point, but, I get a little nervous when coaches and clinicians are really hammering technique and are very stringent with technique. And I don't mean to say that technique is not important. It is critical. But one technique for one person may not work the same way for that other person. That depends on all of these other things that we've talked about. And so, I think we should have some loose guidelines on what's good and what's bad. I mean, certainly, you can't move like a jerk and go to the Olympics in snatching. I mean, you've got to have some basic templates, right? But not everybody squats exactly the same and not everybody snatches exactly the same. There is some variability there. And I think we need to be, as coaches and clinicians, make sure that we're not, not too stringent with that person. I mean, we've got to be able to have some freedom to move in and out because, like you said, I think that you start to stress tissues and you stress the nervous system. So I'm with you completely.
And I think, kind of where some of the variability research I've read is there's a lot of thought about, different types of variability and what, because I got kind of thrown off too, because I was like, all right, if all this variability is great, then how do we learn a pattern? How do we learn to long-term potentially the movement pattern, right? Like, how does it make, like a snatch is a snatch, generally feet here, arm here, hip here, right? And so this is where I kind of understood is there's a coordinative variability, which is the ability to sequence the chain together in a general idea and kind of fine tune the pattern, right? But then there's within that pattern, elemental variability, which is how many strategies do you have to deal with the ever-changing environment, the light, the foot placement, the bar was a little left, right? So you can have a synergy, a motor synergy that is a skill-based thing, but still have variability within that synergy, which allows you more degrees of options to work with,
Exactly. Yeah, that's what I think. I think we're on the same page then with that kind of loose guidelines. But with we have some guidelines that we feel good about on either end. But within that, there's some play based on how that nervous system organizes it based on the environment, which I think is huge. The environment drives so much, and it's so subtle. That kind of comes back to that state-dependent learning, even.
Yeah, absolutely. And so we've kind of been talking about working with the client or person about setting the stage and how to prevent maybe a situation with variability. But let's kind of shift and talk about all right, this person, for whatever reason, does have an injury per se, threat, and they come to us, what are some things that you're using now, you find yourself using regularly that kind of help people in those phases of whether it's education or certain techniques, how do you think we can help people get out of this very sensitized, threatened, rigid, system effect?
Yeah, totally. Well, so certainly, like we've talked about, there's certainly a lot of idiosyncrasies to each person. So, everybody is different. And so one is finding a good history of what those triggers are that sets them off. And that's why, I will, certainly look at, like I said, cognitive load. Obviously, we look at, allostatic load as it refers to training and all those things. But a couple things that usually work pretty much across the board. Let's just say someone is pretty stressed out. And I use that term, they're very sympathetic. A couple things that I will use is some sort of breathing technique. And usually that involves working predominantly on exhalation. We know that exhalation drives parasympathetic tone. So the longer an exhalation is, the more chance we have for parasympathetic tone to increase. And what we see is that people who are typically stressed out are hyperinflated. Right. And so along with that hyperinflation comes extension, specifically spinal extension. And so what I'll try to do is get people flexed and exhaled initially, and that helps just to calm things down and kind of calm the system. Another thing I'll do is I'll do some mindfulness type things where I'll have people count their exhales, not only from a time standpoint as far as 6 seconds out, but also counting them from breath to breath. And what I think that does is it brings some awareness. I tell them to kind of cover the breath with their awareness and really feel. And I think that changes. Certainly, that's interoceptive, and so I think it changes the inputs that they're receiving. It changes their perspective, and certainly helps to increase some parasympathetic. So it kind of brings them back to the body. Because honestly, man, there's a lot of people out there that are not at home in their own bodies. And so kind of bringing that kind of internally, I have found really to be highly successful on the front end. So we'll do some mindfulness stuff. We'll do some breathing and flexion-based, exhalation and flexion-based techniques. And then I'll do a lot of work on the front end with education, specifically pain science education. So, you mentioned Adrian Lau earlier, and Lauren Mosley and David Butler, they have some amazing material. So a lot of times just giving them from a cognitive standpoint, a redirect or reframing the inputs that they're already getting, and kind of tell them, look, you hurt, but you're not injured, right? So there's a difference between tissue damage and pain. And so we've got to, and just reframing that. And there's studies that prove this. Look, if you just educate someone on chronic pain, if you do it well, their pain goes down because they've now changed their cognition, which is all a part of this kind of input, processing, output, mature organism model. Yeah. So that's usually where I start, is breathing and / flexion and mindfulness stuff, and then certainly some pain science education. That's general. Certainly the specifics of each person are addressed when appropriate. But honestly, a lot of times we just got to get them in the right place. Like, don't even worry about necessarily some of these specific impairments. So we're going to do this the first day. I just get people like, hey, let's get it back to square one, and you can engage with me in a interaction where you can pay attention and start to regulate a little bit better.
Yeah, I agree. I think the overreaching concept you kind of highlighted is really important, right? Like, I've found myself more and more on an intake or with a person, it's more about like a solid chunk about like, where have you been? Give me a good history. Let's talk about your current state. It's a lot of pain science. Let's do that. And let's kind of think about where we're going. You know what I mean? People are, I think, previous therapist of me was quick to be like, let's see if I can find something to fix you, manual skill. Now I'm thinking, and I'll help you get there, right? But I don't want you to need me, right? I want you to be able to manage yourself and own your own physical state, like you said. So I find myself doing a lot of what you just mentioned, and then honestly, just like really taking your time and doing a good thorough assessment of their movement, combined with, I guess, a thorough assessment of where they're at cognitively, has really been game changing for me.
I'm with you 100%.
You can really, I found personally, I am definitely into the SFMA system. And I found that, any systems approach will help you get to a spot you want to start with. But I find that if I can spend the time, like a good 40 to 45 minutes, and talk to that person and really understand where they're coming from, and then kind of get through your assessment skill, you kind of leave that first session being like, I really know where I'm going with this person, right? Like, you've established a connection. They feel safe with you. You've been able to calm their system, get them a little bit more parasympathetic with education, and they come back, maybe like, honestly, sometimes like one exercise for home program that really means something based off their movement eval, and they come back and they're like, wow, like I feel kind of good. Like, I feel like good. And even if they're not like cured, they know that you're with them and they're open to your ideas, I guess, is the important.
Absolutely. And that's security. And not only from a social standpoint, but from a nervous system standpoint. Dude, I'm totally with you. And I think, that's kind of, you kind of mentioned about getting a good movement assessment. Certainly that is critical. And I think one of the things too is kind of having a closed loop system whereby you apply an intervention, you test it, and then reassess. You apply intervention, test, retest, and after you've applied that intervention, and get that feedback as soon as possible on how they're feeling. Because what that does is that not only does that give you information, us as clinicians, but also I think it gives them some information on some consistency and some security as far as, how's this going? Hey, that feels good. There's a reward in that. Let's do more of it. Right. Absolutely. And I definitely think I find myself, just like one thing
retest. Like find the most meaningful, Dr. Religioso calls it an asterisk sign, right? Erson calls it an asterisk sign, is in like, what's the one thing that matters to you that is hurt or limited that you need me to help you with, right? And you find that one thing that's personal to them, and you go like, shoulder doesn't move well, like this soft tissue technique, retest. This mode, retest. This one, retest. And it's okay. I had to really kind of swallow my pride when I was getting started. Like, it's okay to be wrong. You know what I mean? It's okay for stuff not to work. It's totally fine. And honestly, that's just one more thing I don't have to waste my time with next time until I narrow in on 3 or 4 really useful interventions that inputs to their system that really, for whatever reason, made a notable effect. And that's their homework. 3 things that are really good for them.
Oh yeah, absolutely. I completely agree with you. And I think over time we start to get better at how, what to look for and those kind of things.
Patterns.
Absolutely.
Yeah. And I think, I don't know why this just sparked into my head, but thinking about like variability too for how we teach motor skill is something I really took away that was really cool from Greg Rose's SFMA too, is how like when we do exercise interventions, it's maybe not all about the same exercise over and over. Like to learn a skill, block practice might be really good, but motor control research has shown us that random practice is pretty effective in long-term retention of the skill, right? So instead of doing whatever, if you're looking at, hip extension, doing a set of 10 single leg hip extensions, but like maybe like 5 different exercises on one hip extension movement that all, I think, thread to more variability within the system. So we have a synergy of hip extension with core control, but we have variability, and it was like, oh, hip was over here and I'm standing on my hip and I'm bending on my hip, but it's extending here and it's sideways here. Like that all plays together to this idea about like, how can you find a meaningful impairment but still make it stick long term?
Oh, absolutely. Totally with you. And I think too, the other advantage of having a variable kind of, having a goal, kind of an underlying principle that you want to address, but different ways to do it, is that also grabs their attention. And if they have to pay attention,
Exactly, yeah.
then you can change the way that they perceive the inputs. And so just grabbing their attention is crucial because, right, I mean, people are hyper-focused on certain areas, that maybe they shouldn't be.
Yeah, right. And this is what I learned a lot from some of your information about how do you keep their attention, right? How do you keep them focused and actively in their prefrontal cortex so that what you say, they actually give a crap about, to be honest, like you're in a busy clinic with people around you, music's on probably, like they're like, my daughter's got to, get picked up in 20 minutes. Like sometimes they're just like out in the clouds and like what you're saying is going woo right through. But if you find, the edge of their ability level and make it, mixed up and entertaining, they really have no chance but to not focus on what you're saying. And if you're lively and you engage them, if you get that 30-minute, 40-minute, intervention session and they're always moving thinking, I think that's a way more success than trying to, just go through some grunt work per se.
Totally with you. 100% agree with you. And that's where we got to, and you've mentioned this earlier, and I think, and just talking to you, I think you do an awesome job of this too, is not relying on these kind of passive treatments, right? Because passive treatments by definition don't require the attention that an active intervention would. And so I'm completely with you. I mean, my standpoint is, and I think you would probably agree with me, is I only do passive if it's absolutely necessary to calm them to a state where they can do active as quick as possible.
Right. I think it's like a very short ends to end means, especially if someone expects it, or if someone's in such a sensitized, rigid state that they can't tolerate much if the threat flag is going to jump off,
Absolutely. Yep.
And it's very, very much taught to them that this is a passage to get you to your own intervention on your own.
Yep. Completely agree with you.
Cool. And I guess the last one I definitely want to see if we could hit on a little bit is talking about, something that we've talked a lot about in relation to flexibility and mobility and developing mobility. And I think it's a really good way to tie this all together about, how maybe pulling on tissues, like we've said before, and doing a lot of aggressive, hands-on therapy may not be needed to, produce change. And I think for me personally, I find that if I'm too aggressive with whatever mobility work I want to do or hands-on treatment, I think that the system accepts it as very much of a threat, and I actually might cause more problems than good and shift somebody sympathetic and start to light up, a very unfortunate response in their system, right?
Sure. Yeah, no, absolutely. I think I've gotten away significantly from, and I think rightfully so, anything that's constituted as a threat. And I think even aggressive stretching. So it doesn't always have to be something that we apply to them. It can be something that we have them do. But what I found is that these people that are amped up, and if we're under the hypothesis that there is increased muscular tone, and increased neural or altered neural state that's causing that tone, by definition, that muscle's not going to relax if we try to stretch it. I mean, it doesn't even make sense. So, excuse me. So I think, pulling on that tissue is only going to serve to increase the mechanical deformation input to that probably already sensitized system. And so, yeah, I'm not a big fan of aggressive stuff that's needed. Now, I will say this: there are some occasions, very few, that if they're late in the stage and it's more performance based, I will do or have them do. Typically, I have them do some more aggressive things that grab their attention, right? Like just a little bit of some quick, on and off things, just to get a sympathetic state up if they need to perform. Like, let's say someone's going to go deadlift some stuff. I'm going to have them do some quick, high velocity movements that generate a lot of tension. And a lot of inhalation type stuff, just to get them parasympathetic, or rather sympathetic, amped to go perform a skill. But clinically, if someone is sensitized, the last thing we want to do is add some more sensitivity to that system. It comes back to this kind of being aware of the effect that all of the inputs have on that patient, and that includes not only the inputs we provide, but also just the environment, the music, the people around. Have they had pain before in physical therapy? How many times have we heard, like, from a physical therapy standpoint, how many times have we heard, oh, I hate physical therapy, they're the torture people or whatever. Yeah, right. I mean, it's ridiculous. It makes me cringe. And it's no joke that they're the people that are back anyway, right?
Yeah, right. Exactly.
So yeah, I'm with you, dude. And how about you? I mean, are you doing much? What kind of stuff are you doing as far as, are you real aggressive with things or no? My guess is no, but I'm just curious your thoughts on it.
Yeah. So I mean,
that love it, man. Love cracking stuff and pushing on hard, things that are hurting. And
yeah, I mean, there's sometimes when if somebody comes in expecting, like, obviously we're talking, both of us probably work in a CrossFit. I work with some dudes who can, squat me ×3. So, like, they come in expecting aggressive, maybe some more, hardcore stretching, feel it, whatever. And if it's going to work for that person, I'll advise them about, the tolerance and things like that. But I personally am not going to be destroying, their whatever, shoulder tissue or whatever it is. They'll get good with a little bit less aggressive techniques, right? And if you test and retest it and it works lighter, then, I've found that personally works for me. But I also spend a lot of my time in a very hypermobile population, right? Gymnastics and people who need extreme ranges of motion to do their sport. And so, especially for me, I think that if we do need, first of all, I think if they have a hypermobile person has a notable restriction, it's either we have some training decisions to change because someone is getting a severe imbalance in how they're training their 3D, or we've put them in a situation, I think, where that movement, that motion, or that activity has produced threat with the system. Usually at end range is where it happens because things start to get real dicey back there, and the system has reflexively locked down, right? So if you are chasing a mobility problem in someone who's hypermobile, or dancer, gymnast, whatever it should be, just mom who is naturally mobile, the reason they're probably in the mobility stuck state in the first place is because the system was insulted neurologically, and it said it's pretty much giving you the big no thank you, and it locks down, right? So if I'm writing the premise that I have to do, I have had to work mobility interventions on very lax people who are acutely guarded, right? But again, I'm thinking that it's neuro locked, and I go more, lighter, and the system kind of gets to unwind, And so I guess that, plus a combination of some of the stretching research on maybe we're not, getting long-term changes in tissue when we stretch. It's much more about the stress reflex or the perception of stretch. And that some of the EDS people that I may see might be lacking that stretch reflex. That's what some of the research shows, and that's the reason they have such mobile ranges. So they may not have, crazy amounts of motion because their tissues are spread like wool, but maybe it's because they lack that perception of an end range. So again, if I'm chasing that idea about an end range and I'm concerned about that, I might want to go more the lighter side. And the biggest thing for me is it's much more important it's not about how you get that person a range of motion, because every input's different for every person. It's about what you do with that motion once you have it, right? Do you learn them? Do you teach them to control it? and maybe, you know, work at that just before they're entering so that they can understand they can work there and their threat is reduced. And then, you know, oh yeah, my shoulder can go there, and like, oh, this is what it feels like to protect my shoulder with scapular motion or with whatever, co-contraction or what it should be. So I'm always looking to change the mobility, do it in a low threshold environment where they can isolate and think about it, build it into a pattern, and then how do we make this stick with long-term changes, you know?
Oh, absolutely. That's epic. That's completely.
Sorry, that was a really long answer to what you asked.
No, but I mean, I think that I mean, the last part but you nailed it, I think, on the head is that last part. I mean, that is the integration, right? That is taking someone from bottom to high performance, and there needs to be more of that.
Yeah, and everything that I guess my approach to working with anybody now has become that kind of idea, right? Look at your overall picture. Why, like, fix something mobility wise, take it to a low threshold environment. Oh, I feel their scap staves for the first time. They're like, shoulders are on fire, right? And then it's like, okay, now let's make it a pattern. And then whatever matters for you, that pattern that exists, whether I'm talking about a gymnast who has to do a very high complex release move, or a mom who wants to bend over and not hurt her back when she picks her kid up, right? How do we make this stick for you? And I found that that's the way that I treat, whether I insert as the manual therapist who does some mobility work or they're doing it on their own. And then how do we work them up that progression and make notable changes that stick around? And I think that's how you get somebody more mobile and then become very strong and make it stick long-term in the nervous system, because the brain accepts it and says, oh, this is actually useful. I should probably hang on to this as a strategy. Absolutely.
100% agree. 100%.
Cool, man. Well, that was a pretty exciting round of 30. So is there anything else that you were burning to talk about?
No, dude. I think we nailed it all between part one and this epic part deuce. We nailed it.
Cool, man. So I guess we got cut off last time because you weren't able to tell people where to find you and stuff like that. I guess talk about what's coming up for the blog. Talk about where they can find you. You know, social security number. Where's your address?
So first off, major props to you, man, for doing this. I'm really liking this idea that you're kind of rolling out, and I look forward to more of these. This has been awesome. So, you know, thank you. And obviously, you know, we talk often, but I love your stuff.
Yeah, no problem.
So you can find me at sethoberst.com. That's with a T. At twitter.com, or at Twitter, my handle is at sethoberst DPT. Yeah, I mean, as far as kind of going forward, I'm really planning on a lot more nervous system stuff and kind of integrating kind of sensory motor, perceptual kind of mismatches, and kind of how we can address some of the ways that the brain is changing our perception of our bodies. So that's kind of where I'm going from that. But yeah, man, that's about it. Big things ahead. Cool. I'm looking forward to some more collaboration with you and some of our other homeboys and girls.
Yeah, absolutely. We'll have to get I don't know if Google Hangouts can handle all four of us. Maybe we can get like a four-way Google Hangout with Dan on here, get Joey on here, get some people on here. We'll have a good old-fashioned round table.
That sounds great, man. I look forward to it.
I think that would get out of hand quickly.
Probably.
All right, cool. And then, so for anyone watching this, I do have to say that we just released a brand new Hybrid Perspective newsletter that is going to have exclusive content fresh before anybody else sees it. So you can head over and jump on that. And then we have some pretty awesome collaborations. We have more webcasts coming. So be sure to check back often. And we appreciate you guys watching, because I'll speak for you on your own, but it wasn't for people watching us and listening to the shenanigans we have to talk about, we would never even get more than 3 views on YouTube. So
I know, it's crazy. It's been awesome so far. So hopefully things continue to look up.
All right, my man. Well, we'll talk to you soon and definitely get you back on. But thank you so much for coming on. We appreciate your brain being spilled out.
You got it, brother. Talk to you soon.
All right. Talk to you later.
See ya.